At Lumibird Medical, innovation is at the heart of everything we do. From precision lasers, ultrasound devices, and cutting edge diagnostic tools, we empower ophthalmologists worldwide with the technology to deliver exceptional patient care.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Paul Singh. Many of you already know Dr. Singh, and he is a cataract and glaucoma surgeon at the Eye Centers of Racemic and Kenosha. Dr. Singh, thank you for joining me tonight.
Thank you. It's awesome being a part of this. I appreciate the invitation. Looking forward to having some fun.
All right, so let's jump right into the case. So you have been taking care of a 72-year-old pseudophakic patient with open-angle glaucoma for many, many years. They are currently using latanoprost daily and timolol twice daily in both eyes. The glaucomatous changes to their nerves have remained stable over the last 3 years. However, they are really struggling to remain compliant with their medications due to arthritis and are now asking you if there are any other options available for managing their glaucoma. They would like to avoid surgery at all costs. Now, Dr. Singh, we have a lot of really great technology available. How would you counsel this patient regarding their options? What are some of the more maybe traditional options available to them, and what are some of the newer drug delivery techniques?
Yeah, no, this is a really great case. I'm glad you brought this up because it's kind of a common case that so many of us see. And there's a lot to unpack here, actually. So it's a really, really well done case because, first of all, it comes to the first thing you think about is this patient controlled, right? You said 3 years, their nerves have been stable. So fields may have been stable. The nerves may look the same on OCT. But is that person really controlled in terms of glaucoma? I would reckon no. And here's why. Because when I think about my definition of controlled glaucoma, it is no longer just the nerves and the field stable, the pressure where I want them to be. It's what's the likelihood of that patient staying on that current regimen long term. If they have a poor likelihood, if there's going to be a high risk of poor compliance, for instance, that's someone who I would say is not controlled due to compliance issues. Because I'm telling you, man, I've been around for 20 years now. I'm an old man now. And I can tell you that I've seen way too many patients who kind of like this are not too bad. They might be mild glaucoma, have a nasal step, pressures are kind of fluctuating a little bit there, but they haven't gotten that much worse. And all of a sudden, one day you come in, you're like, oh my God, what this just happened? I just saw one of those actually just now today. So it is very common to just kind of hit you in the face. So that's why I don't take it lightly, the compliance issues. So definitely trying to get the patient, or already the patient saying, I have arthritis issues. So they're having a hard time physically taking it. They're probably not taking it very often, especially that BID dosing drop like timolol, which I usually use in the morning now anyways. So it's not just about dry eye or about them not remembering. It's physically, can they take the medication? So the fact that she's asking about other options, that's rare because a lot of people won't ask. So my caveat to all this is even if someone doesn't ask you, don't assume that they want to stay on drops, right? Just because they're like, oh yeah, I'm not having a problem with drops. If you say, hey, I do with drops, oh, I'm doing fine. A lot of times they'll say fine, but when you really inquire, a lot of them don't remember the names of the tops. They can't remember the color of the tops. They don't get to the pharmacy in time. They have fluctuating vision as a cornea specialist. You can tell me, right? Fluctuating vision, ding, 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 dry eye, right? And so all those different clues to someone's non-compliance or poor compliance is something we have to pay attention to when there's patients are in our room. So back to your question, what can we do, right? So obviously there's preservative-free options to get them off of the BAK, but really for this patient, it's about getting them off the drop because of physical issues with arthritis. So there's a few different things, as I'm a big fan of something called SLT, selective laser trabeculoplasty. And basically, this is now considered a first-line treatment in many parts of the world. In the UK, Gus Guzzard and his LIGHT trial, the 6-year data set that compared latanoprost versus primary SLT in patients, found that patients over 6 years had less chance of progression, less chance needing cataract surgery or glaucoma surgery with the SLT group versus the latanoprost group, even though the pressures reduction was the same. So that tells you that even though drops may work, there's probably some fluctuation, probably some compliance issues, and visual field loss was actually less in the SLT group. And just to remind everybody, SLT is basically a beam of light. And the way I describe it to patients, it's a beam of light that stimulates the drain in the eye, the trabecular meshwork, right? To stimulate so the eye can heal itself and rejuvenate. That's what I tell patients. Your eye is going to rejuvenate itself. So I don't use the word laser. I don't say it's going to be a laser. They say, oh my God, no way. I say, look, your eye is like a water balloon, and the eye makes fluid to keep the shape of that balloon, right? The shape of that eye. But the eye, inside the eye, the water has to drain so more fluid can be made. Your drain's not working. So I'll do a beam of light that takes just a few minutes in the office, covered by insurance, that can rejuvenate the drain so your body can heal itself. It works about 75% of the time. If it doesn't work, then we can always try other options. So I think it's how we describe SLT, but as a first line, it's the most physiologic way of approaching why our pressures are going up, the trabecular meshwork. So instead of diverting fluid away like timolol, which is decreasing aqueous production, or using latanoprost, which is pushing fluid into the uveoscleral pathway away from the trabecular meshwork, let's try to rejuvenate the drain. Let's try to keep it patent and hopefully modify the natural progression of the disease. That's why I love SLT so much, because you're actually addressing the pathology directly, you're decreasing the potential for compliance issues, and you're keeping all of your other options open for MIGs, for other drops, for other surgeries as well. So that's why for me, SLT would be first. Now, if you tried SLT and it didn't work, or you still didn't get your pressures low enough or wasn't off of all the drops. Let's say you did SLT, but they still needed, let's say, a drop a day like a Timolol, and that was hard for her. You can always consider drug delivery, right? Drug delivery has been a huge hot topic for us now over the last few years when Durista, which is bimatoprost sustained release by AbbVie, which is basically a small microscopic pellet that is released with a small 28 gauge needle. We press it through the limbus at the slit lamp, or even if you want to lie him down, but at the slit lamp, we press a button, click, and it goes in truly within like a couple seconds. And it sits there and it sits in the inferior angle and releases bimatoprost over 4 months. It's basically one drop of Lumigan that is in this small pellet. But because it's in the eye, we don't have to worry about the corneal barrier. As you know, the cornea doesn't like things going in the eye. So we need a higher concentration to get stuff through the cornea. And so basically, this is just one drop of Lumigan, one drop of a PGA that lasts you for 4 months. But the efficacy, the actual duration of effect, even though it's only releasing for 4 months, we're seeing data now 50, 60% of patients getting 1 year of efficacy, up to sometimes 25, 30% of patients getting 2 years of efficacy. So there's those responders that respond much longer. We can go into some geekiness there and why that is, but there's definitely a significant difference between topical and intracameral, meaning in the anterior chamber, in terms of the longevity. Even though the drug is not being released anymore, the effect is longer. So that's called Durista. And the other one would be iDose, which just came out, just got approved actually this year. Back in February, we were the first to do one here in the US, which is basically a travoprost drug delivery platform. So Glaukos makes the iDose, and it's basically a small, non-degradable insert that basically has travoprost oil in a little proprietary kind of mechanism with a little luting membrane that releases it 24 hours a day for, now we're saying 2 to 3 years, if not longer. If you look at the data, and what that is basically, it's like an eye stent in terms of it goes through the trabecular meshwork. So it's actually a surgery, like an eye stent, but you go, instead of going into the canal with like a stent, you go through the TM and you basically insert this in the scleral wall. So it has a little kind of a anchoring part of it that just goes straight into the scleral wall, and you release it and come out, and that's it. And it just stays there. And it releases medicine 24 hours a day at this travoprost oil. And if you look at the data at 2 years, there was a part of the study, they took out some of these implants to see how much implant or how much travoprost was still left in there, and about almost 20, less than 20% of the oil was still left in there at 2 years. I think it was like 17 or 18%. So that tells us that there's probably good 3+ years in a lot of these patients. And I was in the phase 2 trials and 3 trials, and we did have patients up to 4 to 5 years still having efficacy as well. So those are the drug delivery platforms that we can utilize that can help get this patient off a drop in a very safe way. One is done in the office, or it could be done at the ASC, which is Durista. And then the iDose is more of a surgical procedure, although it's very quick and very efficient. It's more of a surgical procedure as well. But both of them are safe and have been shown to be very safe from the endothelial cells overall, as well as from a inflammation or adverse event profile. And we can go to more details on those, but those are the two drug delivery platforms that I would say would be a good option for this patient. So you could do either SLT first or after this drug delivery, or do the drug delivery in combination with SLT and see if that would get her off those drops. Sorry, that was like a long soliloquy, but so
No, that was great. You're already starting to answer a lot of my questions, but one kind of silly question that I'm just going to ask because I'm sure the listeners are thinking about this too is once you put the drug delivery system into the eye, So for example, does Durista dissolve, or do we have to remove it later? Like, what is the management there?
No, it's a great question. Yeah, sorry I didn't bring that up. So yeah, so Durystazo iDose, the second one from Glaukos, is non-biodegradable. It's a titanium implant that stays in the eye. So even when the drug is gone, just leave it there. It's pretty inert. The Durysta is a pellet that's really biodegrades or dissolves into two components, lactic acid and glycolic acid. So that is a dissolvable implant. The vehicle, the interesting thing about Durysta is that even though it's releasing drug for 4 months, the actual vehicle, the implant itself, can actually last sometimes a year, even longer. So you may see the pellet still there, and it gets smaller and smaller and smaller. But even a year out, you might see the pellet. It's not releasing medicine, but it's still there, kind of sitting down the inferior angle. But it does dissolve on its own. Good question. Thank you.
So are you able to repeat? So let's say Durista 2 years later, are you able to implant another of the devices, or is it kind of a one shot? Is it like SLT where we wait an X number of years and then retry?
That's a great question. So I'm going to give you the official answer, the FDA approval answer, and then what I do in real life. Okay. So the FDA approval answer for AbbVie and for Durista and for iDose is a single administration. So one time and you're done. That's what AbbVie is going to tell you, and that's what the FDA official labeling is. Now we'll talk about why that is in a second. But what I do in my clinical practice off label is absolutely when they have responded well with Durista. Let's say it's been a year out and the pellet is a little small, little left, even if it's small, like 20% left, I will insert another one. And I'll tell the patient, to be honest, this is off label. Doesn't mean it's illegal, just means it's not on the labeling. But since it worked well for you, I was part of the trials, I feel very comfortable doing another one of these. And I've had a number of patients, we've done a second, even a third now, since it's been around for a few years now. And it's so far been, knock on wood, been very safe, and we've gotten approval for majority of these. So it is something you can still do. And I'd say for all the young listeners out there, it's really important to understand this concept of off-label versus illegal. Because off-label, we do so many things off-label. Avastin for intravitreal injections for AMD was off-label for years before we got approved. Using antibiotics around perisurgical, perioperative use of antibiotics rather is also off label. It's not meant for around surgery. So there's a lot of things we do on a day-to-day basis that's off label, but it's still considered standard of care or considered still within the scope of our practice. You just got to make sure that you get insurance that may not cover it, and or the patient should know about it. That's kind of my perspective on it. So why though was it only approved for a single administration? So in the phase 3 trials that I was part of, we were inserting Durista, these little pellets right here in the office. We were doing it every 4 months for 3 insertions. So 3 insertions every 4 months. Now, we had no clue, and no one had an idea of how long it was going to last and how many we should do at one time. So we said, let's just try, hedge our bets, do it every 4 months and see what happens. Now, it was shown that 5.4% of patients had up to 30% loss of endothelial cells. So not a lot of patients, and no one had clinically significant loss of vision. There was no edema, nothing like that at all. But because it was numerical enough, the FDA said, hey, let's hold off and just do one insertion. Because with one insertion, no one had 30% loss, only 0.9% had any significant loss. So why did it happen? Why did we see some of those select patients have some cell loss? It was because the vehicle doesn't dissolve at 4 months, right? So if the vehicle is still there, you put a second one and then a third one, let's say a few months after that, they can stack on top of each other in the anterior chamber, in the inferior angle, and they can start to touch Schwabe's line and go above that into the into the endothelium of the cornea. Now, again, not very common. It didn't cause any significant clinical issues, but because it was a numerical, of course, the FDA was like, no, 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 let's just do one. So that's why. And with the iDose too, I think they just felt the same thing, even though they had really good ECL data. So the endothelial cell loss for the cornea was very good with the 5-year data of the iDose. They still gave that labeling because I think the FDA is still worried about all these intracameral things. So that's what I would say is off label. You can do it. On the labeling, it is for one single insertion. So really good point there.
So, since we're talking about some of the adverse effects, can you tell us a little bit about how you counsel patients and what are some of the adverse side effects of having any of these drug delivery systems?
Yeah, that's a great point. So I think two things. I want to talk about how I described, and I'm going to back up even more if it's okay. If okay, if I back up even more and talk more about just how I approach glaucoma today with these patients, because With this interventional mindset, this interventional glaucoma that you hear about all the time now, this terminology, it's not about rushing to surgery. I think that's a misnomer. People think, oh, okay, you just want to get surgery done on every patient. It's really about the mindset that we are utilizing multiple technologies early in the disease course to minimize the need for further surgeries, but to also appreciate compliance as an issue. And any one procedure may not be enough for the rest of their life. So it's about setting the stage for our patients to say, look, Mrs. Smith, you have glaucoma. Good news, it's early and we can take care of it. We have multiple different ways of delivering medications in the eye. We have a beam of light that can rejuvenate the drain. We have minimally invasive ways to open the drain up, or we have other surgeries that can bypass the drain. We have multiple things we can do over time. I'm going to try right now something I think is going to maintain the highest quality of life and still get the pressures down. If it doesn't work, we'll try the next something. And so that spiel of expecting more than just this I'm doing for you is really important to set that stage. Also, number two is if you set the stage that not one thing is going to work for everybody or work forever, if your treatment doesn't work, you're not freaked out. Because one of the biggest concerns that a lot of colleagues had now with all these new methodologies and new procedures we have is like, well, what if it doesn't work? What do I do? What do I tell the patient? Oh no, they're gonna get mad at me. You say, no, that's okay. Well, we try this instead now. Or we go back to drops if we have to, right? Drops are still always there. We're not evil with the drops. It's just that try to get them off as much as possible. So that's the one thing I talked to them initially about. So then when I talk about drug delivery, I say, look, Mrs. Smith, most of my patients who get drug delivery have had SLT already. And also are back temporarily on a topical PGA. Not everybody, but a lot of them are. So I said, look, Mrs. Smith, I pick a barrier to compliance to have the discussion. So for instance, it's not about selling something or telling something, convincing them, I want you to have this. You're saying to a patient, Mrs. Smith, you're telling me that your eyes are irritated. You're telling me that your vision comes and goes. Your eyes are red. You're forgetting. Pick this patient, you have arthritis. You pick any barrier to compliance that the patient divulges to you, and that's your trigger to say, you know what, I'm going to help you. So you're the answer to their problem versus trying to convince them to do something. So you say, okay, Mrs. Smith, you're telling me that your vision's coming and going, or here, this patient, you're telling me you're having a hard time physically taking the medication drop-wise. Don't worry. I'm going to deliver that same medication with a small microscopic pellet. Let me replace it right here in the office. Just like the same place right here, we get your eye pressures checked. I just press a button, go click, and it goes in the eye. That's Durista. And it goes in the eye. And it releases that medicine 24 hours a day. One drop of that medication you're taking at night, and it can deliver it 24 hours a day. So you don't have to take drops for a few months, maybe 4 to 6 months, maybe longer. And we'll see how long it lasts. When it does go back up, we can either go back to drops or talk about other options. And it's a very simple, basic assumption that's going to go up. We have other options if we need to, but let's try to deliver that same medication you're taking, but delivering in a way that doesn't make them scared. If you say there's a needle we can inject here in the office, they're going to say, see ya, peace out, I'm done. But if you say, hey, I can gently place this medicine in the eye right here at the lamp, or the same place you get your pressures checked, all of a sudden it's like, oh, sure, why not? And we say it's covered by insurance, not Medicare Part D. This is part of your medical insurance. I know for all the young surgeons out there, you're like, what is he talking about? Well, in real life clinical practice, trying to get medications covered, especially brand name medications, takes a lot of time and effort from our staff doing what we call prior authorizations. Because a lot of companies, insurance companies, don't cover a lot of the medications we want to use. So you have to do a lot of loopholes to get in. And there's a separate insurance for that, not your medical insurance. It's your drug plan insurance. That could be a pain. So that's why we tell patients this is not a drug plan insurance thing. This is your medical surgery, like your normal insurance that can take care of this. And so I think those are the kind of things that I say, Sila, just to help kind of make them feel comfortable. And it's very calm. It's just saying, oh yeah, this is what I recommend for you. And another pearl I would say to all the youngins out there too, is make sure anytime you're offering a patient something, make sure you offer it with conviction and confidence, not selling. You never want to sell something to your patients. You want to truly believe in it. If you don't believe in something, don't do it. That's what I would say. But if you truly believe X, Y, and Z procedure or device or drop, whatever it might be, is the best thing for that patient, for their eye, then you got to believe it and you got to hold true to it and you got to tell them, this is what I think is best for you. Don't be afraid. They want us to tell them that. And there's a big fear, I think, for a lot of our surgeons, especially the ones who've been out for a while, who are used to giving drops and drops and drops, that, hey, our patients want drops first. I can tell you, they want us to tell them what's best for them. And if you believe in it, you feel confident in it, you got to tell them, this is what I do for you. And this is what I do in my practice. This is the standard of care in my practice. So that's what I tell them. Now, that's what I tell them to get them to do that. But I do say, look, everything we do has some positives and some negatives to it. So what are the negatives of these drug delivery platforms? Well, It's not going to last forever. That's okay. We have, like I said, we have other options if we need to. Sometimes the eye can get inflamed. So I'll give you my spiel, but really the phase 3 data showed a few percentage points of patients who had some transient inflammation. So I've had a couple in my career where you see give them some NSAIDs topical, like, ketorolac or Prolenza or Bromfly, whatever you use. And basically that can help calm any inflammation. So say, I can be a little irritated with this pellet, and not a problem at all if it does. The risk of infection is theoretically there, but I've never seen one. It's a very microscopic way to deliver it. But we also make sure that we look for infections for the first few weeks, first week rather, just to make sure. And then the last case scenario, if for some reason your eye doesn't like it, we can always remove that pellet if we need to as well. So that's kind of my spiel, and we have a consent form we sign that has more into it. But that's kind of stuff I talk about: inflammation, risk of infection, and if your eye doesn't like it for some reason, I can always remove it very easily in the office if I have to as well. So that's kind of how I talk about it. But yeah, inflammation. There was no endophthalmitis in the studies, thankfully, of Durysta or iDose. We talked about ECL, but there's no one in the studies had any endothelial cell loss that caused corneal edema per se as well. So the way I couch it to my patients is sometimes your eye doesn't like it, it's something in the eye, so we can always remove it if it has to be, but it's extremely rare for that to happen. I have, to be fair, removed one Durysta and one iDose for patients who were not good candidates. That was my bad. So like I said, the one patient had a history of HCV, herpes zoster, and had inflammation in the past. Not a good idea. And so I did a Durysta on that patient. I took that patient's pellet out because it was causing some inflammation. So I took it out. And then one patient also who had a very bad reaction to every single medication and had high allergies. And just even though the eye dose was not causing any inflammation, she just internally got freaked out when I put it in her eye. And after a few weeks, I took it out. The eye dose was nice and quiet. I actually have a video on that. So, but you can take them out. So worst comes to worst, you take them out and you're okay. So that's what I tell my patients. I know it's a long-winded way of saying that's how I tell them.
This is for the young surgeons out there. This is so helpful. I know that I myself am taking so many little nuggets from everything that you're saying, like, oh, I'm going to say that, or I'm going to use that when I counsel my patients. Just kind of reflecting back on not the ideal candidate and that concept. You obviously had this patient with zoster. Anyone, I guess, I'm guessing with uveitis or a history of repeat inflammatory conditions. Anything else that we need to know about that would kind of make us think, okay, this is not the best patient for one of these drug delivery systems?
Yeah, that's a really good point. Thank you for bringing that up. So yeah, you want to make sure the right patient. So first of all, the most important thing is everybody out there, even if you're not a glaucoma specialist, even if you're cornea, gonioscopy. I know it's fun, right? But do a gonio in every glaucoma patient. I'm sorry, but it is so key, especially in today's world. When I was a resident, actually, it was like, yeah, okay, do a gonioscopy unless you think it's narrow. Don't worry about it, right? But now, because of all the MIGs and drug delivery and SLT, you really should look at the angle and see what's going on. So getting used to the angle and knowing if it's open or narrow or not is very important. But even within the context of open, you want it to be a grade 3 or 4, we call Schaefer grade. Basically, you want to see the ciliary body, sclerospur, trabecular meshwork, Strubby's line. You want to see the whole thing. The reason why, especially the Durysta, it sits down at an inferior angle. Even if you have an iris, so if you do a gonioscopy, sometimes you look at your gonio and you have an iris and you see the iris kind of bowing, kind of like almost like convex. It's kind of like going up because you have a natural lens in the eye. Or let's say you have a patient who's hyperopic, even if they're open, but the lens is pushing forward and causing the iris to have like a dome shape to it. So there's a narrow approach, we call it, to the angle. Even that's a patient I would hold off on. You want to have a nice wide open angle so that way the pellet can sit in the inferior angle away from the corneal endothelium. In the iDose as well, you want to have a nice open angle, grade 3 or 4, so that way it's not sticking up, touching the cornea, that little pellet, or that little device rather, or going down and hitting the iris as well. Now, if it does hit the iris, it's not going to cause a problem in the studies. If it did, we just left it alone. But it can lose efficacy if it's blocked, right, by the iris as well, or cause a potential inflammation. So open angle, that's the most important thing, first of all. Now, once you have an open angle, you've done your gonio, you feel really good about it, then exactly, you want to have good, healthy cornea. So we have a cornea specialist here. So I could talk about making sure you don't have Fuchs. If you have some endothelial dystrophies, some strange endothelial problems, I would hold off on that just because the fact that these are in the eye and, they technically could cause some cell loss numerically. And why look back and say I should have done it? So any kind of patient has Fuchs dystrophy or any kind of endothelial cell dystrophy, hold off on that. You're absolutely right. Uveitis, if they have a history of uveitis, HCV, HSV, some other inflammatory autoimmune condition that had a history of uveitis, I would hold off. There's other options. It's not worth kind of doing that and then causing a problem potentially. But pretty much outside of that, it's a pretty open season for most of these patients. So either they're phakic, they're pseudophakic. In the studies in Durista and in iDose, we didn't see anybody who was phakic, meaning natural lens, converse or convert to a cataract. No one developed a worsening cataract within the 2-year studies. So this is something we see in patients who have one medication burden, two medications, three medications. There's a huge value to even getting off of one medication. That's a thing I hear a lot too, Sila, is I hear a lot of people saying, hey, you know what? They're already on two or three meds. So what's the Durista or a iDose going to do, just getting them off of one med? Well, if you look at the studies that the phase 3 trials and clinically, first of all, even if you get someone off of one med, you're decreasing the chemical and the preservative load. Number two is the amount of cost you're increasing is improved. Number three, what you find is a lot of patients, especially on generic medications, like two or three of those, by doing this one pellet of the Durista or iDose, you're getting some of these patients off of not just the PGA, because remember, these are just PGAs, but sometimes because patients are not compliant with other medications, they're actually able to get off of two or even three meds too sometimes. So you'd be surprised. So it's okay to do these on people, not just with one medication or two meds, even three meds. Just got to be honest about what the expectation is. You tell Mrs. Smith, I'm going to do this little pellet of medicine delivered here, but it may not get you off of all your meds. But if I get you off of one or two, that's great. Let's try it and see what happens, because it's so safe. So the expectation is different because it's so safe, especially the Durista done in the office. But those are the key, I think, adverse events and the key watchouts for those patients, just to make sure they have open angles, corneas are healthy endothelial-wise, and don't have a history of inflammation. And then if they have really, really high pressures, like pressures of 45, 50, put them on drops first, right? Put them on drops, get the pressures down, and then we can talk about drug delivery later on as well.
Is there a way for young ophthalmologists to learn the insertion techniques? Do they have wet labs? Where can people learn this technology?
If you want to get started with these things, just utilize your local reps, the AbbVie reps, the Glaukos reps, other company reps are always willing to teach and educate. They'll bring a portable little mini wet lab with you and a little fake eye to do these different things. They'll do some didactic teaching. They'll put you in contact sometimes with other ophthalmologists who are on their medical advisory board and other speakers. Reach out to them in meetings, AAO, ASCRS, some of the smaller meetings. They will have wet labs. They'll have courses that you can sign up for as well. And then, of course, reach out to colleagues. One of the beautiful things about our profession in ophthalmology is that we have truly, truly a supportive group of doctors. And this new wave in the last decade has been so tremendous of just saying, yeah, man, I want to help my colleague out. And so please reach out to everybody, and locally, internationally, nationally, more than happy to help out, myself included. Anytime.
I love that. We're so lucky. I mean, I know that my generation is like, I'm constantly texting my near peers. So the people that are maybe 5 years out and just getting their ideas. And so we're really fortunate to have such a diverse network of surgeons that we can lean on. Dr. Singh, this was an incredible episode. I know that I certainly learned a ton of new information that might even change how I practice, since I am seeing some of these early glaucoma patients. Thank you so much for joining us on this episode of the Pupil Pod.
Thank you. Awesome. This is so much fun. Appreciate the opportunity.
And thank you to those tuning in. See you next time on the Pupil Pod.